Hi, my name is Stephen Chan. I'm here at the University of California, Davis. I'm thrilled to be here at our Future Health. We're looking at patients who have a lot of complex medical issues, and I'd like to share some of the things that we're going over. So I'm going to go briefly share the screen. So one of the things that I see in my practice are people with a lot of mood issues. And one of the things I remember most is my first case. I saw one of my friends actually come into the hospital, and she was there because she was in the midst of something called mania. Mania is where you feel so revved up, you can't control your own sort of excitement, and you may not be sleeping, you might not be drinking or eating properly. And she was there because she was an undergraduate who had basically was arrested by police because she was banging on pots and pans at 3 a.m. in the morning. So she came to me in the hospital, and this is what happened. She was there. She said, Dr. Chan, I can't stop. I really don't want to be here. And she was starting to cry. And then she started laughing, jumped up, and then leapt all over to the bathroom to brush her teeth. And it made me realize, this is something that could happen to any of us. And we as doctors look at vital signs. We look at numbers. We look at heart rate, blood pressure, temperature, and how fast we're breathing. All of these are numbers that we track over time. These are vital signs. But we often don't track the vital signs of emotion. Whether someone's happy, whether someone's neutral, or whether someone is sad. For most of us, we are around the neutral area. We kind of have our up days, and we kind of have our down days as well. Sometimes, though, we feel some people experience profound depression. We call feeling down, not feeling any pleasure, or they want to even harm themselves because they feel like life is not worth living. There are those who suffer from a different type of depression called bipolar depression. Bipolar depression is not just on one side of this pole, this timeline, but they also flip into the other side where they're unusually happy, or even too excited, too unusually happy, and maybe even think that things are real when they're not, or they're having delusions, or they may be feeling quite hyped up or overactive. So if you actually think to yourself, well, this can't happen to me, this can't happen to any of us, this is quite unusual, but believe me, 1 in 5 of the world's population experiences a mental health condition in any given year. And this is the same for the United States. What's even more interesting is that if you take the population, a subset of the population, such as Southeast Asians in the United States, even more of them face mood disorders. 71% of them meet criteria for major mood disorders like depression. In fact, 81% among Cambodians and 85% among the Hmong people, because they've fled war-torn countries to seek a new life. But they come with a lot of emotional trauma as well. Trauma because they're also having issues with acculturating to the United States, say. They face language barriers. They face stigma, racism, bias, poor quality and culturally insensitive care. And because of this, they may find that they have less access to treatment. They may be less likely to receive treatment, and they also have a lower rate of health insurance. So this is enormous. This has enormous implications for healthcare. This is not the disease itself, but this is actually their own well-being and how they behave, and how they approach the healthcare system. In the United States, for instance, the #1 leading cause of disability are neuropsychiatric disorders. You see at the top, this yellow bar is the highest, and it's the greatest percentage of total disability-adjusted years in the United States. Now, what you also see on the bottom is a small number percentage, but still significant, due to self-harm and interpersonal violence. And we'll talk about a bit more of that later on. Mental health is really important, and depression is the #1 cause of disability in the world. According to the World Health Organization, there are 10 risk factors contributing to depression. And this is from an article by Henry Nasrallah, a physician and professor. And he says that allergies, gut changes, obesity, a sedentary lifestyle, and dental disease, sleep, diet, smoking, stress, even exposure to sunlight that can cause low vitamin D. All of these are risk factors that can contribute to depression. And my colleague, Harvard professor and psychiatrist, Arsha Vahabzadeh, says that these risk factors can contribute to a whole lot of other chronic conditions: diabetes, heart disease, high blood pressure, back pain, obesity, cancer, asthma, arthritis, allergies, problems with the sinus, feeling down, depression, lung disease, kidney disease, and high cholesterol. And all of these conditions can be driven by depression. And these can really cause an enormous number of total costs for all chronic illnesses worldwide. And then I see a lot of folks who have depression and anxiety, but I also see people who have these delusions and hallucinations. This is actually a stock photograph, but all of the people I'm talking about have been anonymized and the details have been changed. But I see people such as young teenagers who are suffering from schizophrenia, who have an otherwise normal life beforehand, and then afterwards they start seeing things that aren't real, hearing things that aren't real, or believing things that aren't real. They feel scared. They also may experience something called negative symptoms, and these negative symptoms cause them to not think as clearly. They don't feel like they're able to pay attention as much. They're not able to focus. They're not able to live the life that they used to lead. And so when someone has this condition or they start experiencing these symptoms, where do they go? In Sacramento County, all of these blocks are touch points in our mental health care system. And there are so many touch points. It's a bit difficult to figure out where to go because of the intense number of entry points. There are places where you can go for learning about the issues, community support teams, there are access points, and then there are all sorts of specialty outpatient clinics. And if someone is feeling very much in danger to themselves or they are out of control, they may have to go to a locked hospital. Those who don't recover and have to live with their disease and they're just permanently impaired have to go to a locked down nursing home. And it's because a lot of our therapies really are not curative. Business leaders and venture capitalists have taken notice of this, but the reason why the amount of finances have been low is because these are quite difficult patients. These are some of the most complex patients. This particular venture capitalist I spoke with at HIMSS said that he never wants to deal with them because there are businesses, but they're not low-hanging fruit businesses. These are businesses that have to touch on social issues, psychological issues, and medical issues. These are all these issues are so fragmented, but these fragmented systems can really be an opportunity for new mental health platforms. So if you look at, say, telehealth, for instance, telehealth it can be considered a mental health platform, yet it's still in the United States in its nascent stages. So this is actually a graph that from IBIS, and this shows that 645 million United States dollars are invested in telehealth, but only a small sliver is devoted to mental health. Now, mental health can also affect all of these other issues that you see on the screen. The orange slice is lung diseases, that red slice is heart issues, and then, of course, you see the gray, which is just mental health. But if you look at mental health within the United States, we're spending billions of dollars, billions of US dollars on psychiatric hospitals, on mental health and substance use disorder clinics, counseling and crisis services, as well as alcohol and drug rehabilitative services. So all of these services could use some more coordination and could use some more technology to help streamline care, boost access, make care more efficient. And one way people are doing that is by adding cognitive behavioral therapy services to apps, to platforms. And CBT is something that has been tried and tested for decades now. This is where we take, where we show folks that your thoughts can really influence your feelings. So if you're thinking that you're not going to, say, ever get a job promotion, you might feel down. The feelings can influence behavior and situation as well. And then this goes in a circle. What we try to do in traditional therapy is target the behaviors and thoughts. These behaviors and thoughts can then influence feelings. So for instance, if we try to identify the critical behaviors, such as someone not going out of their house and then they subsequently feel even worse, we might want to get them to stop staying in the house. If they have too much staying in the house, we try to decrease those behaviors. If they have too little of a good behavior, we try to boost those number of behaviors. And this kind of therapy is manualized, which means that it can actually be delivered by a computer. There have been so many studies on how cognitive behavioral therapy can help with depression and anxiety. And in fact, you can even weave these principles in video games. This particular study was published in 2012, and it's called SPARX, SPARX. And this video game was used to target adolescents who needed help for depression. This was made in Australia. They tried to commercialize the video game, but I don't think that that's in existence. However, the principle and the research remains the same. It's something that you can use in video games and applications. But if this is for depression and this is for anxiety, what can you do about other people who are facing much more severe illnesses? I mean, I see people like this case number 3. I see I saw recently, for instance, someone in their middle ages who was facing, who had faced quite a bit of violence in the past. She had faced abuse, physical abuse, and sexual abuse by her past partner. And, you know, folks like them, folks like her, and folks like veterans too, who face life or death situations often experience something called PTSD, or post-traumatic stress disorder. This is post, meaning after the trauma. And then they get an enormous amount of stress, but not the kind of stress that most people would get. But this is stress where they feel on edge all the time, feel anxious, or they feel like they are reliving the nightmares over again. In fact, they may have nightmares every night that wake them up, and there they are, reliving the trauma again. Can we do something to help them, or can we potentially use technologies? Such people often have issues in between therapy sessions, but issues like trying to keep in control, keep cool. But what if there was an app that could help them? One of my acquaintances and colleagues, Dr. Ruzek, is the director of the U.S. Department of Veterans Affairs, the National Center for PTSD at Stanford. And his team created an app called PTSD Coach. This particular app is targeted towards veterans, but you know, it's actually been deployed around the world and targeted in places like Australia, where other military veterans and service members are dealing with stress. This particular app can help manage symptoms, assess the symptoms, and coach, essentially, people with PTSD, and help them avoid triggers and learn how to teach them how to decrease their anxiety. They also have deployed other apps such as Mindfulness Coach. This one can teach meditation, teach mindfulness, teach them body scanning techniques with audio and guided exercises. And they can track people's progress as well. So these are all freely available online on Google Play and Apple's App Store. In fact, they have at least 11 total mental health apps last I counted. And this has big implications. The government, major institutions, insurance companies are all looking at mental health apps. But what if we can extend that even further? What if you could, say, make them intelligent, and able to engage with you? There's actually a new app that Daniel Kraft is associated with at Singularity University. X2 has something called tests that actually will respond with you and actually provide a sort of this cognitive behavioral therapy. And I've seen only just the prototypes of it, but it's also made headlines. Recently, they deployed something with a variant of this app to Syrian refugees because, 1 million Syrians have fled to Lebanon since the conflict, and many of them have been dealing with this trauma as well. And if you look around the world globally, the number of people in low-income countries on the left-hand side of this graph, they face a shortage of people who are working in mental health, which is shown in the green bar. This particular graph is from Health Affairs, a 2014 article called How Google's 10 Things We Know to Be True Could Guide the Development of Mental Health Mobile Apps. And there they argue that the red line showing the number of mobile phones to the mental health labor force is quite high in the low-income communities compared to, say, high-income communities, where there are a lot of mental health therapists, clinicians, doctors, a lot of mental health workers. Can we use these smartphones? Can we use these mobile phones to give to people in low-income countries, or, in fact, in underserved areas of the United States or even urban countries? So the United States' top mental health researcher, Thomas Insel, recently joined Google's former life sciences division called Verily, and he has written about how technology can cover much of the diagnostic process of psychiatry. A lot of the treatments for mental health are psychosocial interventions, and those can be done through a smartphone as well. And if you look at the smartphone, there are so many different parts of the smartphone that can be useful, that can, for instance, detect location, detect how fast you're going, detect how you're using the internet, detecting how you're texting or communicating, detecting your voice, and how much light you're exposed to as well. All of these have been, actually studied, and there's a review in current psychiatry reports on how these can help with measuring mood, classifying personality, even tracking movement for, say, drug interactions or drug side effects. And a lot of these are part of the growing trend of using technology in mental health. My research mentor and friend, Peter Yelwees, is a professor at the University of California, Davis, and he is the new president of the American Telemedicine Association. And he has written about how e-mental health can help deliver or enhance mental health services using technology and the internet. He predicts as well personalized medicine can help individualize treatments and therapies for patients. Business intelligence can help guide how businesses and how services are deployed. And then population health as well can use technology to understand and address health determinants, such as the acculturation issues and the social issues that I talked about earlier. And technologies can also really address the underserved needs, such as rural health, female or women's health, seniors, homeless, specific diagnoses such as PTSD and schizophrenia that I mentioned. So all this is so exciting. You've got apps that can help you not only just track your mood, like this simple app. This can help track your mood over time, but also warn you if you are going near a trigger or a bar, say, if you have an alcohol use disorder. This particular app by Patrick Doolin and his colleagues at the University of Alaska actually can help reduce cravings by reminding people who use the app why they've stopped using alcohol in the first place and guide them away from high-risk drinking situations. Some of my other colleagues as well at the University of California in San Francisco are using intelligent platforms to mine data from journal entries that are written by service members and veterans. They use the data in these journaling statements as narratives, and that are fed to IBM's Watson predictive personality insights platform. And they're using that to see if they can detect whether someone is on the downslide, if someone is relapsing, or if they are improving. All of these are used something called machine learning and big data, and this can really drive population health and individual health that we talked about earlier. And this particular graph that you see is from IBM Watson, where they are actually telling you what kind of emotions you're facing. Smartwatches, for instance, Polaris Health has created an app that's used in different trials, such as at MD Anderson Cancer Center for a breast cancer trial, where they use responsive adaptive questions to generate and predict treatment responses as well. They've got a lot of funding from the government, and they're using this for a variety of other conditions. Virtual reality is another area too that can really enhance psychotherapy. Sius is one of the companies here, PSIOUS, and they create scenarios for people with specific phobias to help them get over their fears. Now, this has to be used with a therapist, of course, especially for something that can be anxiety-provoking. But can you just imagine social anxiety, alcohol use, PTSD can really benefit from this. And there are decades of research that the University of Southern California and the government has invested into, say, facial recognition and virtual therapists. Facial recognition software can help detect someone's emotions on their face or their body activity as well, and whether they're smiling, whether they're frowning. And it's much more in wide use now, thanks to Microsoft's and Google's new technologies that are being released. And my colleague, Arsha Vahabzadeh, who's a physician and an entrepreneur and professor, he all rolled into one, is helping his colleague Ned Sahin here with something called Brain Power. It's a wearable education system for children with autism so that it can help them make eye contact and detect emotions and learn people's emotions. There's something similar to this at Stanford University. Duke University is also using something similar with Apple Research Kit, where they are detecting faces and emotions of those with autism. One of my colleagues here at the University of California in Davis has created wearable technologies where children with autism can, excuse me, express their emotions with motion sensors, light sensors, speakers, and even speak into microphones as well. Even eye movements can potentially tell whether someone has a cognitive issue, schizophrenia, or autism. So these are all sort of future technologies that are in the works. They're not really in full clinical use yet, at least here in the United States, but they can potentially help reduce a lot of the puzzling parts of psychiatry. Now, communications is an important part. Now, how we communicate with therapists has always been face-to-face, but increasing number of companies are deploying these telemedicine technologies that can also be smart as well. There are also research projects around this. This one particularly, you see me here as a patient, speaking with one of my colleagues who's interviewing me, is a University of California, Davis project called asynchronous telepsychiatry. Asynchronous means that it's not at the same time. You don't have to be there at the same time. You don't have to be there at the same place. It's asynchronous. You take this video and you send it to the physician, and then they can diagnose and send treatment recommendations. And they can potentially use the video for other purposes in the future as well. And Dr. Yellis is the lead researcher on this for asynchronous telepsychiatry. And he's found in his other studies with his colleagues that it's diagnostically reliable. It's actually pretty good. It also helps with language barriers if you couple it with translation as well. He doesn't suggest it for therapy, though. It's not for one-on-one therapy, but it can be used for monitoring treatment progress. And it's also useful for easier management and scheduling, and it really helps improve communication between the patient and their doctor as well. Medication adherence technologies are still experimental. This one is from AI Cure, where they not only do facial recognition of someone's identity, but also identify the medicine and confirm that they've placed it in their mouth and ingested it. And you know, medication adherence is a huge problem. Something as simple as a medication tracker on the phone or the smartwatch can really help, especially if you're caring for multiple loved ones at home. So all of these are apps, and these apps number in the hundreds already. Hundreds on the Android Google Play Store and the iPhone's App Store. And only a handful of them, though, are of good quality. A lot of them are not that good quality, which I'll talk about later. But there has been an explosion of mental health startups. And if you track them over time on AngelList, which tracks the number of startups in the space, there were only 3 mental health startups in 2012. This tripled to 9, and then I would say increased to 53 by the end of 2014. By the end of 2015, there were 162 startups. And right now, there are 192 total companies. And if you actually categorize all of these companies, they fit into some categories, but a lot of them straddle different categories. Provider platforms, big data and machine learning platforms, telemedicine and telepsychiatry, self-help platforms, as well as devices. All of these are joining the fray in the startup technology world. Of the 192 mental health startups on AngelList, though, only 109 of them joined in 2015. So that was over half have just joined within the past year. And I'm deliberately showing you the power of all the phones. And these extend to phones that are just a few years old, too, just like this one. But what if you had phones that were old? One of my patients actually came in. I saw them in drug court, and a drug court is where they go to get services to treat the underlying depression and anxiety after a drug offense. They may have possessed something that was dangerous to use or illegal to use. And he held up this phone, and he called it a government phone. The government here has been giving out phones freely, apparently, but these are old phones. This one is 2009 Palm Pre, which still has web access, but none of the apps are available on their app store anymore. And this is a challenge. What do you do for those who are the most underserved and the most neediest, but maybe they don't have access to the technology? What if you were dealing with outdated research methods? Right now, a lot of research is based on too many pilots. There's really no standardization amongst the apps. And the methodology is a challenge because technology is going so fast. There's also data interoperability issues. If you take, say, the number of research publications, which you see in the white bar graph here, those are still roughly the same over the past decade, but the amount of funding for research, creating these apps, has actually ballooned quite a bit, yet we're still producing the same amount of publications. And the reason why is because if you take any sort of research process, such as the Federal Drug Administration here in the United States, they take years to research a drug, right? At least 15 years, up to 15 years, just to approve a drug in terms of safety. Now, can you imagine waiting 15 years for a research study on technology to come out. 15 years ago, if you were doing that, you'd be doing research on really old black and white phones, in fact, dumb phones. And unfortunately, a lot of the research studies that in the past couple of years have only begun to scratch the surface of apps, because a lot of the research has been based on old technology, phones like this. In fact, the hype cycle is quite enormous at times. You've probably seen this at Gartner, where they say that there's a lot of hype around technology, and then it kind of crashes down and dies. But then it reaches a plateau of productivity. But the hype is still there for apps. Articles such as this, can your phone cure depression, have come out more recently. But can you guess it? This article was published 4 years ago. Apps really do get outdated quickly. And none of the apps in this article have been cited or available for years. My colleague, John Torres at Harvard, has written about how mental health apps are based on flimsy science and that they have not been thoroughly tested. And he's written about things like this, and people have researched about how apps in the medical space, such as these researchers, they tested 79 apps, and they actually got a copy of the data sent over the network. They found that a lot of these apps were leaking information. Half of the apps included strong identifiers in transmitted information, such as email addresses, login details, people's full names, or even their date of birth. So there's a lot of privacy risks when it comes to apps. And the reason why I mentioned this for mental health specifically is because mental health is such a sensitive subject. The most fatal disease that we have in mental health is suicide. And suicide warning signs can include a depressed mood, suicidal plans and intention, drugs and alcohol use. Now, try to find an app that can cure this, or at least detect suicidality. We don't even have a very good, strong, reliable way of doing that in clinical practice. Now, there are some apps, such as My3, that can help guide someone and try to get them to not think about suicidality. But this kind of just shows you the depth and complexity of mental health. There's an enormous amount of things to consider. There are a lot of things to make sure that you are aware of and try to avoid, such as suicide. One venture capitalist says that things like this, guide coaches or the guides that you see, it's not adequate enough to just have an app layer on top of interventions. It doesn't really answer the real problem within the healthcare system. So we often then, the next step is, how can we judge these apps? My colleagues and I have released a lot of app criteria where we've recommended people use reputable institutions, trying the app themselves first, and having doctors talk about security, privacy, and lack of testing, at least to just give people a heads up that, hey, there may be some issues with these apps. But despite all of these issues, there is a lot of good that can come out of them. The University of California has so many people working on mental health technology. People at UC Davis, the Mind Institute, the School of Nursing even is looking at depression measures in diabetes. University of California, San Francisco has a digital health core in the psychiatry department working on cutting edge technologies to help people with debilitating disorders. UCLA and UC Riverside have centers where they create such applications. And here in our lab here at UC Davis, we're also testing interpretation in clinical scenarios. This one particularly has a translation issue deliberately because translation technologies are not yet mature, but they're pretty good. Now, can we use that to harness people's language barriers, or overcome language barriers? People want these apps. We've done studies in Harvard, University of Wisconsin, UC Davis. We've seen that people, a lot of them own smartphones in psychiatric clinics, and almost 3/4 of them are really, really open to the idea of using smartphones for mental health. And of course, this skews to a younger population and privately insured. So This has implications. People are empowered. People are now managing their own health. This is a Regina Holliday's artwork from Stanford Medicine X. And they even have societies of people who want to manage their own health. Employers are trying to encourage their employees, here in the United States at least, to be more well and to exercise. And people are even tracking their symptoms down to the day-by-day graphs online. This is from patients like me. Places like Kaiser Permanente are also looking at transferring a lot of the care from hospitals to the home. And they're even seeing if they can shift a lot of the care so that people can take care of themselves. Now, this is actually a photograph from a place called the Innovation Center. The Garfield Healthcare Innovation Center is a fake hospital, fake clinic, fake house where they're testing all these technologies out. This is a view from their fake hospital room, their fake NICU for babies, and their fake operating room where they can test all these technologies out. And then they guide people and their researchers and their physicians through different scenarios. And here's a view of their fake house. So if you're thinking about all these technologies, think about the underserved, think about the people who can't afford phones, think about the people who have the most debilitating issues, domestic violence, PTSD, people who have cognitive issues, who can't think for themselves, who have issues with reality testing, and then not just the people who have depression and anxiety. So I come back to my friend who I talked to earlier. She was the one who I saw in the hospital. And I remember feeling really, really down every night and feeling very, while I was there doing my medical school rotations. And I felt helpless. I felt like I couldn't do anything for her to help ease her suffering. And I met her afterwards. I met her after her recovery. She was recovering in the hospital where they provided her medicines to stabilize her mood. They gave her some talk sessions so that she could talk about her emotions. And then they gave her a calm, soothing environment. And she recovered. And I saw her a couple months later and for coffee. And, something that she said was really interesting. She told me that she said, "I'm afraid that I'll have an episode one day where I never recover, though." It's a really scary thought. It's kind of like cancer in a way. So much of our healthcare system is devoted to diseases of the heart, diseases of the lungs, diseases of cancer cells. But there isn't enough attention being paid to mental health. There is booming attention, but as I showed you, but there's still a lot of work to be done. So if you're interested in learning about how mental health technology works, there are numerous venues, numerous events to go to. This is one such event. You're at Our Future Health, and I'm grateful that you've joined me in learning about this. The American Telemedicine Association, at least this is a US-centric viewpoint, and they have a mental health track. The National Council of Behavioral Health Administrators holds an annual meeting called NatCon, where they talk about technologies that they can deploy in their community. And the Association for Computing Machinery, or ACM, holds human-computer interaction interest group conferences in mental health. They also have affective computing groups and something called pervasive computing groups, which deals with computers that are everywhere, Internet of Things, in your environment. So there's a lot of work that can be done. Please join me. Please tweet to Stephen Chan MD, at Stephen Chan MD. And again, I'm here at UC Davis Health. In 1 month, I'll be joining the folks over at UC San Francisco for clinical informatics, where we're hoping to drive more technology and mental health innovation. I'd like to thank my colleague Arsha Vahabzadeh, Peter Yeolis here at UC Davis, and the American Psychiatric Association as well as UC Davis's Department of Psychiatry as well. Thank you for having me.